Today, I'm going to talk about renal replacement therapy in sepsis. I declare the following conflicts of interest as displayed in the second slide. Sepsis and acute kidney injury are joined at the hip. Sepsis is the most common risk factor for acute kidney injury, and sepsis-associated acute kidney injury accounts for about 50% of all severe AKI cases in trials of renal replacement therapy. Patients with sepsis-associated acute kidney injury, KD goes stage 2, have about a 50% chance of eventually needing renal replacement therapy. And of those patients with AKI that go on to receive renal replacement therapy, about 50% have a 90-day mortality. Unfortunately, there is no specific treatment for this condition, and all treatment is supportive. In particular, the major supportive technology that is applied to the care of these patients is renal replacement therapy. So that brings up the question of how should we use renal replacement therapy in these patients? There are essentially two major modalities that are applied to the care of these patients in ICUs in the developed world. They are continuous renal replacement therapy or intermittent hemodialysis. There is also a technique known as slow, low-efficiency dialysis, or SLED, which is applied in some centers to the care of these patients. It appears to account for around 5 to 10% of all treatment modalities in ICU septic patients in the trials that have been reported. Peritoneal dialysis is also used, but typically in low-income countries and in children where vascular access is problematic. There are no large randomized multi-center controlled trials focused on comparing these modalities in the treatment of septic acute kidney injury and indeed acute kidney injury in general. So we don't have a robust understanding of whether the choice of modality makes a difference to outcome. However, we have sought to address, and there are two major trials that have tackled the issue of renal replacement therapy intensity. One is the ATN trial conducted in the USA, mostly in Veterans Administration hospitals, which use a protocol which combined continuous renal replacement therapy and intermittent hemodialysis to test the impact of dose on mortality. And the other one is the Renal trial, which was conducted in Australia and New Zealand and only used CRT and again assessed the dose effect on mortality. The ATN trial was published in the New England Journal of Medicine now 13 years ago, and it's a randomized controlled trial comparing two intensities of treatment. One is 35 mils per kilogram of body weight during continuous veno-venous hemodiafiltration. The other is 20 mils per kilogram of effluent product with CRT. If the patients were hemodynamically stable, they were treated with intermittent hemodialysis either daily or second daily. This is the flow diagram of the trial. 1,124 patients were randomized, and about almost all of them were able to be followed up to 60 days. These are some of the key characteristics of the patients at baseline. Of course, being a randomized controlled trial, they were balanced at baseline. I'm showing this slide to show you that about 53 to 56% of patients in this trial had septic acute kidney injury. So the majority of people had septic acute kidney injury. As you can see here, with high intensity and less intensity, there was no difference in outcome in terms of mortality in hospital or death at 60 days or recovery of renal function. This is the Kaplan-Meier survival plot showing time to event, again, showing no difference between the two interventions. When you do a forest plot, looking at whether SOFA score, or the presence of oliguria, the sex of the patients, and the presence of sepsis were affecting in any way the differential mortality of these two techniques, and you can see there's no difference. The second trial is the Renal trial, published in 2009, and this is, again, a randomized controlled trial, but focused on continuous veno-venous hemodiafiltration. And you can see that it compares an effluent flow of 40 mils per kilogram to one of 25 mils per kilogram with 90-day outcome as the primary outcome measure. This randomized 1,500 patients, again, good follow-up, limited loss to follow-up, and a very robust trial. You can see that the baseline characteristics of the patients are identical. And again, I'm emphasizing here that 50% of the patients, similar to the ATN trial, had sepsis as the trigger for AKI. Again, like in the ATN trial, there was no difference in mortality according to intensity of dialysis treatment, establishing that there was no need to increase the intensity of dialysis above 20 to 25 mils per kilogram per hour of effluent generation or GFR equivalent, because it does not increase the likelihood of survival, and of course it increases the cost of care. And this is the Kaplan-Meier survival plot, also showing time to event. This is the forest plot of the renal trial, also showing that according to the presence of organ failure or sepsis or a GFR below or above 60 mils per minute, there was no difference in outcome. The two trials, however, had significant differences when compared head to each other in the degree of renal recovery, such that in the VA ATN trial, at 28 days, 45% of patients were still receiving renal replacement therapy, which is very different from the renal trial, where only 13% were still receiving renal replacement therapy, suggesting differences in outcome between these two trials beyond what they were randomized to. And one of the fascinating difference between these two trials is the amount of intermittent hemodialysis the patients were exposed to during the time of treatment, which was significantly greater in the ATN trial than in the renal trial. And this has led to a recent investigation which combined the two trials and was able to do an individual-based data meta-analysis adjusting for illness severity. And what it found, as you can see that in red and blue, is that the proportion of patients after adjustment and comparisons between the degrees of illness severity at randomization that was dependent on dialysis was significantly greater in patients that were treated in intermittent hemodialysis mode compared to those treated with continuous renal replacement therapy. And when one compares, again, the patients that were exposed to intermittent hemodialysis, the first treatment, versus those that were exposed to CRT as the first treatment, they, as you can see in red, the number of patients that experienced mortality or failed renal recovery was significantly greater after exposure to intermittent hemodialysis as the first treatment of choice. So it looks like it might be desirable to avoid intermittent hemodialysis and favor continuous renal replacement therapy. And it looks like greater intensity of treatment is unwarranted. What about timing? When do we start? This has been addressed by several trials. This is the Akiki trial conducted in France. And this trial randomized patients to have early intervention with renal replacement therapy or a delayed intervention strategy with renal replacement therapy to test whether intervening early with this treatment would or would not help patients survive more. Again, you can see there that if you put together the patients with sepsis or severe sepsis and septic shock in the Akiki trial, they really made up almost 3/4 of all of the patients, implying that what we saw in this trial is highly relevant to septic AKI. The major findings of the trial were that if patients were randomized to a delayed strategy, a number of patients, about 30-35%, never actually needed to receive renal replacement therapy, either because they died or because they recovered. The mortality on the left was the same in the two groups, but of course the cost of care was greater with the early intervention because it carried the need for intermittent or continuous renal replacement therapy being applied potentially unnecessarily in about a third of patients. When one looks at the effect of this approach, you can also see that the urinary output was decreased in the early strategy, suggesting that exposure to renal replacement therapy decreases urinary output. However, in this trial, intermittent hemodialysis was the technique of choice in almost half of the patients. So it's unclear what would have happened if all of these patients had been treated with continuous renal replacement therapy. The second study to address timing was the IDEALS trial, which was actually focused on patients with septic shock. So this is very specific to sepsis. This is about 500 patients were randomly allocated to early versus delayed intervention. Again, balanced randomization, similar characteristics at baseline. All of these people had septic shock. And you can see there was no difference in outcome in terms of mortality. Of course, there is a decreased use of renal replacement therapy with a delayed intervention, but no difference in mortality as to whether you wait or whether you intervene late. This Kaplan-Meier survival plot confirms with time to event analysis that there was no difference in outcome. However, again, a significant proportion of patients in this trial, about a third, receive intermittent hemodialysis as the first and initial and fundamental treatment modality, which is different, for example, from the renal trial, where continuous renal replacement therapy was applied to everybody. So again, it is unclear what the results of this study would have been if all of the patients had been treated with continuous renal replacement therapy, as was the case in the renal trial. The AKIKI 2 trial then addressed the question of why don't we wait even longer? And the AKIKI trial compared delayed intervention to markedly delayed intervention, which really waited for a blood urea nitrogen above 110 or a urea concentration above 35 millimoles per liter. So delayed versus very delayed intervention. This is a smaller study of only about 140 patients in each group. But again, the majority of these patients had septic shock, suggesting the relevance of this finding to such patients as well. Again, fewer patients received a renal replacement therapy in the very delayed intervention group. And you can see there that when there was an assessment of sepsis and the association between delayed strategy and outcomes, you can see that on multivariable analysis, a more delayed strategy on the right was associated with a 65% significant increase in mortality. And so this trial shows that excessive waiting, prolonged waiting in a population with a significant presence of septic shock and sepsis is associated with greater risk of mortality. So early intervention does not seem to be necessary. Delayed intervention seems to be equivalent, but delayed intervention beyond the usual levels and going to a very delayed mode is associated with increased risk of death. The timing of initiation was then finally addressed in the largest trial of them all, the START-AKI trial, published in the New England Journal of Medicine 2 years ago. Again, this is a much larger trial involving 3,000 patients. And again, a significant percentage of the patients in this trial had septic acute kidney injury, making the findings relevant to this population. Again, there was no difference in mortality between early or accelerated intervention or standard or delayed intervention. But a key finding of this study was that if patients were allocated to delayed intervention or standard strategy, their likelihood of being renal replacement therapy dependent at 90 days was decreased. Or put another way, early intervention increased the risk of renal replacement therapy dependency at 90 days. Again, however, in this trial, there was a significant use of intermittent hemodialysis, and whether this was partly a contributing factor to delayed recovery or non-recovery remains to be tested. And of course, the observation of multiple adverse events potentially associated with renal replacement therapy, particularly hypotension, raises concerns that the modality of choice might have played a role. This is the Kaplan-Meier survival plot, which looks totally identical for the two delayed and accelerated intervention. And this is the forest plot, which shows that in all the different subgroups of the trial, there was no difference between the two strategies in terms of survival. So let me conclude my presentation saying that there is limited data entirely focused on renal replacement therapy for sepsis-associated acute kidney injury. However, in all major trials, sepsis-associated AKI represented approximately 50% of all patients, making extrapolation from global data to SA-AKI quite reasonable. Such extrapolations imply that greater intensity of renal replacement therapy is not helpful. They also imply that early intervention may not be helpful, and in particular, that in some patients, early intervention may even increase the risk of failed recovery to dialysis independence at 90 days. The trial data implies that conventional criteria for renal replacement start are desirable and appropriate, but that further waiting for prolonged oliguria or a BUN above 110 or a urea above 37 may be injurious. Some of the trial outcomes, however, may have been affected by the choice of protocol and the use of intermittent hemodialysis in a significant proportion of patients. If only continuous renal replacement therapy had been used, the results might have been different, and this issue requires further investigation. And indeed, in this regard, further analysis of the START-AKI trial will be addressing these issues in the next 12 months or so. There are many unresolved issues, but there are some key unresolved issues. What is the ideal modality for these patients? Intermittent therapy or continuous therapy? What is the ideal fluid balance in renal replacement therapy in these patients? What is the optimal rate of fluid removal, the so-called net ultrafiltration rate during this therapy? Is the use of more advanced blood purification techniques potentially helpful in septic AKI? Does advanced hemodynamic monitoring, intravascular volume monitoring with continuous hematocrit sensors potentially improve outcome? Several of these issues are likely to be addressed in developing trials and investigations and research programs, and we will hopefully have some answers to these important questions in the next 5 to 7 years. Thank you very much for your attention.